Good evening and a very warm welcome to each and every one of you who have joined us today for this webinar. I am Dr. Reshma Quadros. I am from the medical team at Sun Pharma. And today we are going to get in through a very enlightening session for all of us. So just before we begin, I would like to give a brief introduction. Let me share my slide. Yeah. So this month being the PCOS Awareness Month, we've taken this initiative to share as much as we can regarding the clinical insights, and we have a renowned person with us to share these insights with all of you. We already know that at least 1 in 5 Indian women suffer from PCOS, and this was out there in the newspapers in the Hindu. It had come out. But if we look from the literature perspective, the prevalence is as high as up to 22.5%. So, without further ado, I would like to welcome Dr. Jayashree Gopal ma'am from Chennai, who is the senior consultant endocrinologist at Apollo Hospital, Chennai, to please enlighten us regarding PCOS. Ma'am, you can please share the introduction slide. Yes. So, ma'am is the director at Diabendo India, Chennai, which is the Institute of Diabetes, Endocrine, Metabolic, and Lifestyle Health. Ma'am is also the founder, trustee of Diabendo India Foundation, preserving health across generations. Ma'am is a diplomate of the American Board in Internal Medicine, Endocrinology, and Diabetes. So, like I already mentioned, she's the senior consultant endocrinologist and diabetologist at Apollo Hospital. Ma'am has so many accolades under her name. As you can see, ma'am is also the vice president of Endocrine Society of Tamil Nadu and Puducherry. So, ma'am has also numerous published literature and chapters and books under her name. We couldn't document all the accolades here in one slide, but we are very happy to have you here with us, ma'am, to share with us your experiences, your clinical insights, and from an endocrinology perspective to all gynecologists here today regarding PCOS. Over to you, ma'am.
Yeah, thank you very much for that very, very kind introduction. And it's a pleasure to be here among you all. And I'd like to thank the organizers for inviting me to give an endocrinologist perspective about how we approach PCOS. And just 1 minute. Can you see my slide with the PCOS?
Yes, ma'am, we can see.
Okay. And it's full screen?
Yes, full screen visible.
Great. Thank you so much. This is always a little bit hit and miss sometimes. Like I said, this is an endocrinologist perspective. Not that it's very different from the way a gynecologist sees. I think the main difference is the sort of the time in which they come and they present to us. So to endocrinologists, they present with different problems, and to the gynecologist, they present with different problems. So the management may vary a little bit depending upon their presenting complaints. And as Dr. Quadros mentioned in the brief introduction, PCOS is the most common endocrine disorder among reproductive age women, among all women for that matter. It is estimated the prevalence is anywhere between 8 to 20%, depending on the population studied. And we'll talk a little bit about diagnostic criteria, but we are all very familiar with the fact that they use 2 or more of either irregular menstrual cycles or clinical or biochemical hyperandrogenism, or a polycystic appearance of the ovaries. But as endocrinologists, our main role is to make sure that we are not missing these secondary causes. So we need to make sure that they do not have untreated hypothyroidism, untreated hyperprolactinemia, and in rare cases, congenital adrenal hyperplasia and Cushing's. So this is our role mainly as an endocrinologist, to make sure that we are not missing any of these secondary causes. Of course, PCOS, like I said, they can present across the lifespan. They may present to us actually as endocrinologists fairly early on because of features of early puberty. So they present to the early adrenarche or a tendency towards development of axillary hair or change in the body odor at a very young age. Sometimes we see young girls as young as 7 years and 8 years presenting with this complaint. Of course, they may present sometimes with delayed menarche. And more often, we are seeing young girls who present at the age of 15 or 16 with significant insulin resistance with primary amenorrhea as the presenting symptom of PCOS. Then, of course, we have the usual presenting complaints of hirsutism, acne, infertility, and other metabolic-related complications, which become more common as women get older. But this is happening at a younger age. So it is not unusual to see women even in their sort of mid-20s with some combination of these various metabolic factors like dyslipidemia, NAFLD, fatty liver, sleep apnea, and so on and so forth. And of course, later on in life, having a diagnosis of PCOS increases the risk of cardiovascular disease and certain malignancies, partly may be related to the obesity and insulin resistance, which is a major component of PCOS always. So I want to spend some time talking about how we diagnose PCOS, and I think it's also important to know when is it not PCOS. So sometimes there is a tendency to label all young women with irregular periods as PCOS, and obviously it is important because the management varies. And I'll talk a little bit about some newer recommendations regarding the evaluation and how do we tailor management and some aspects of the controversy around the management. The sort of the diagnostic criteria, the recommendation from the guidelines has changed a little bit, but not significantly. The main difference is, do we need to have irregular cycles or hyperandrogenism or polycystic looking ovaries? Do we need all three, or do we need two out of the three to make the diagnosis of PCOS? And currently we use the Rotterdam criteria in general because that tends to be the most applicable clinically, particularly in India. In India, we do not see much by way of clinical hyperandrogenism. We do not see much by way of biochemical hyperandrogenism. We do see very commonly women who present with polycystic ovaries and chronic anovulation with some features of clinical hyperandrogenism, a little bit of acne, a little bit of hirsutism, but not the whole biochemical type. What are some of the things we need to keep in mind while making the diagnosis? Remember that symptoms are very varied and that there is no one specific diagnostic feature. So, for example, if you take a group of women presenting with PCOS or suffering from PCOS, 75% of them would have ovulatory or menstrual dysfunction. Somewhere between 50 to 80% would have biochemical hyperandrogenism. And even among the biochemical hyperandrogenism, the sole androgen elevated may be free testosterone in some people, but some studies have shown that androstenedione may be the androgen alone elevated in 10%. Similarly, DHEAS may be the sole androgen elevated in about 25%. So depending upon the background of the population studied, so it's partly related to age and partly also related to the ethnicity that determines which androgen level goes up. And in our country, we see various combinations of high normal free testosterone and elevated DHEAS at a younger age. About 15 to 25% may present with acne alone, and this is usually acne that comes on during puberty. And of course, then we have the other features of hirsutism and 60%, polycystic ovaries and 75%, and insulin resistance in pretty much everybody, but impaired glucose tolerance probably in about a third of young girls who present with PCOS. So as you can see, there isn't one single feature that is seen in all 100% of women with PCOS. So it is a diagnosis. Sometimes making the diagnosis is really an art. We need to be able to put together various metabolic parameters before making the diagnosis. The only place where this is different is in adolescence, where we need all three criteria. We need a combination of clinical and biochemical hyperandrogenism, irregular periods, and the specific criteria for polycystic looking ovaries before we label diagnosis of PCOS in adolescents. This is because acne, for example, that we use as a feature of clinical hyperandrogenism in adults may be quite normal in adolescents. So we cannot use that as a criteria. Similarly, polycystic ovarian morphology of the ovaries is very common in the first 3 years after menarche. Again, we cannot use that to make a diagnosis of polycystic ovaries. So currently what is being recommended is that in adolescents, rather than making a blanket statement saying that you have PCOS either based on a scan or irregular periods, look at their other metabolic parameters. Do they have features of insulin resistance? Do they have some acanthosis? Do they have an increased BMI? And say maybe suggestive of or at risk for PCOS, and keep evaluating them and encouraging lifestyle changes before making a blanket diagnosis or statement, which sometimes causes a lot of stress in these young women, because there is a lot of social media awareness about PCOS. So sometimes people get worried unnecessarily when they are diagnosed and sometimes mislabeled as PCOS. And also keep in mind that in adolescence, oligomenorrhea or amenorrhea can occur for at least 3 to 5 years after menarche. Ultrasound should always include increased ovarian volume in this case, and hyperandrogenemia documented clinically, biochemically should be present. So all three criteria need to be present to diagnose PCOS in adolescents. Now, the third aspect that we need to keep in mind when we are making a diagnosis of PCOS is how do we interpret androgen levels? So if we look at the androgens, the commonest androgen that we measure is testosterone, followed by sometimes DHEAS and a 17-hydroxyprogesterone. Testosterone is predominantly partly derived from the adrenal cortex, circulating testosterone, partly derived from the ovary, and a large percentage is actually from peripheral conversion, particularly in adipose tissue, which is why women with a higher percentage of body fat tend to have higher testosterone levels. If you look at DHEA and DHEAS, most of it is derived only from the adrenal cortex. Circulating androstenedione is derived 50-50, both from the adrenals and from the ovaries. The three androgens that are commonly measured are testosterone, DHEAS, and 17-hydroxyprogesterone, and we'll talk about it. Not all endocrinologists agree on measuring DHEAS. I still think it is useful in certain situations. If you look at testosterone per se, it gets broken down to the active form, which is the dihydrotestosterone in the skin under the influence of this enzyme, the 5-alpha reductase. And this is the form of testosterone, which is actually can bind and activate the androgen receptor present all over the body. And of course, in the ovary, it is converted to estradiol and other estrone under the influence of aromatase. Very high levels of testosterone would suggest more than 2 to 3 times upper limit of normal. Of course, we are taught to make sure that there is no neoplasm. Do we measure free testosterone or total testosterone or with SHBG? It depends upon the lab and availability. Some labs, particularly for the labs which do a lot of research, prefer to do total testosterone and SHBG, and with that they derive a androgen index, free androgen index. Whereas free testosterone assays have become somewhat more accurate over the years, and provided it's a good lab with whom you have been working for a number of years, you can consider using a free testosterone. So it depends upon the lab and availability. DHEAS, studies have estimated that 50 to 60% of young women with PCOS may have elevated levels of DHEAS. Why is it important to know? I think it's useful to measure it at least once. It is a good marker of underlying insulin resistance. The levels tend to be high on puberty till about the early to mid-20s, after which it tends to come down as women get older. Very high levels are suggestive of Cushing's disease and rarely of congenital adrenal hyperplasia. Similarly, it's a good idea to check a 17-hydroxyprogesterone at least once. It is not uncommon to pick up non-classical CAH in our population also. And depending on the ranges of the assay used, if it's less than 200 nanogram per DL, it is normal. If it is more than 1,000, it is diagnostic of CAH, and between 200 to 1,000, they need evaluation for non-classical forms of CAH. DHEA is not measured because it's got a very short half-life. If you need to measure an adrenal androgen, I would prefer that you measure a DHEAS. Androstenedione, in general, we do not recommend measurements. Similarly, dihydrotestosterone, we do not recommend it be measured. So the main androgens which are measured are testosterone, DHEAS, and 17-hydroxyprogesterone. Of course, keep in mind that when testosterone levels are very high, DHEAS levels, normal DHEAS is somewhere between around 100 to 350 or so. If it's more than 700 or 750, think of adrenal tumors. If the testosterone is more than 200, it could indicate either an adrenal or an ovarian tumor. A high suspicion for congenital adrenal hyperplasia should be maintained when the DHEAS levels are high, when it is associated with early onset of puberty. So if the girl says that the mother says that the girl started developing pubic hair at the age of 6 or 7 years and she's presenting at the age of 15 with PCOS features, think about CAH. Again, very significant clitoromegaly or significant hirsutism at a young age, think of CAH and investigate accordingly. Of course, a relatively older woman, say a woman in her mid-20s to 30s, sudden onset of weight gain with development of dysglycemia, hypertension, white striae, think of Cushing's. Cushing's is easy enough to evaluate. I think it's a good idea anytime you have a doubt to rule it out. A recent article which was published in our diabetes literature showed that in a population of people with diabetes with difficult to control, poorly controlled glycemic status, nearly a third of them have uh, uh, unsuppressed cortisol levels, and some of them did have a adrenal adenoma. So unless we look for it, we may not be able to pick it up, and sometimes the diagnosis is missed. It's a simple enough test. We just have to give 1 milligram of dexamethasone at bedtime, usually between 10 to 11 p.m., and check our cortisol the next morning. It's a very simple test to do in the OP basis. Just make sure you're not combining that cortisol test after dexamethasone with any other lab report. In very rare situations, we need to keep in mind other rare endocrine problems like acromegaly. Also remember that any contraceptive pill, particularly those containing estrogen, will suppress LH and FSH up to 3 months. So we cannot interpret low LH, FSH if they've been on the contraceptive pill. All androgens are preferably measured in the fasting state in the mornings. If they have regular cycles, they need to be measured in the early follicular stage. If the woman is amenorrheic, you can measure it at any time. Now, what about hirsutism? How do we assess hirsutism? Of course, we use the Ferriman-Galway score, and hirsutism is defined as the terminal hair growth in the androgen-sensitive pilosebaceous units. And apart from the usual places which are obvious clinically, like the upper lip and the chin and the upper chest and abdomen, we also need to keep in mind the upper thighs, the upper back, and the lower back. These are all, if there is excessive hair growth here, very suggestive of a hyperandrogenic state, sometimes PCOS. Hirsutism is a very good marker for hyperandrogenism, but it has to be interpreted in an ethnic context. So we know that there is a lot of racial variation in hirsutism, and isolated acne and alopecia are not necessarily related to or good markers for hyperandrogenism. So when we see hirsutism, it should be evaluated biochemically. In general, when we are treating hirsutism, we need to have prolonged medical therapy. And anytime we use anti-androgens, as I shall be discussing, particularly in the reproductive age women, ideal to combine it with contraceptive pills. Now, I spoke a little bit about how to interpret and which androgens to measure and how do we document and measure hirsutism. What about the irregular cycles? So oligomenorrhea, again, this audience knows exactly what it is, less than 6 to 8 cycles per year. Amenorrhea as a presenting feature in PCOS is seen in less than 5%. Remember that both amenorrheic and oligomenoric women may be ovulating. It doesn't mean that they are anovulatory. In fact, 30% of women with PCOS have regular cycles, but even when they have regular cycles, that's not always ovulatory. So keep in mind that just having regular cycles does not mean necessarily that you're ovulating. And just because you're amenorrheic does not mean that you're not ovulating. Both these extremes exist in PCOS. In general, it tends to improve with age. So by the time a woman with PCOS enters her early to mid 30s, mostly the periods tend to start settling down. And in general, the more irregular the periods, the type of woman that we see who's got one or two periods a year means that they have a more severe PCOS phenotype. Remember that not all irregular periods is PCOS. So if this irregular cycles is combined with low BMI or sudden weight loss or intense exercise, particularly without hirsutism, think of hypothalamic amenorrhea. Anyway, we would be checking an LH, FSH, and amenorrhea. If it is on the lower side, think of hypothalamic or pituitary causes. And similarly, if this young woman presents with hot flashes, vaginal dryness, we need to obviously keep in mind premature ovarian failure. And we would check an FSH and an AMH in this situation. Now, coming to the polycystic looking ovaries, of course, these are all well-documented guideline recommendation. Ideal to do a transvaginal, but in adolescents, obviously, we prefer to go for transabdominal. We need at least 12 cysts, presence in with an increase in the central stroma and volume, particularly in adolescents. Presence in one ovary is sufficient. Remember that if they are using oral contraceptive pill, it would have modified the appearance. So absence of PCOS cannot be taken as a cure of the PCOS anytime, but particularly if they've just finished a course of oral contraceptives. If they have a dominant follicle or their corpus luteum seen, then the scan needs to be repeated. Ideally, the scan needs to be done in the early follicular phase if they're having regular cycles, or in the oligo or amenorrheic phase, if they are there either randomly or 3 to 5 days after a withdrawal bleed. So these are all some of the things to keep in mind when we are evaluating the ultrasound appearance of polycystic ovaries. Remember that 30% of women can have polycystic looking ovaries. So just a polycystic appearance of the ovaries does not classify a woman as having PCOS, and many other conditions can cause PCO, particularly hypothyroidism and hyperprolactinemia. More and more over the years, we begin to realize that PCOS comes with a lot of other baggage. So for example, there is increased risk for endometrial cancer, and this may increase by anywhere, it may be double to increased risk as much as 5 times. Particularly, I'm talking about the obese woman with significant insulin resistance, who's getting only 1 or 2 periods a year. This is the type of phenotype that I would be most worried about developing malignancy in the long term. There does not appear to be an increased risk of breast and ovarian cancer, and there are no specific guidelines in the PCOS population on how to screen for endometrial cancer, apart from saying that we need to be aware of this increased incidence and prevalence. The insulin resistance and obesity increases the chances of fatty liver, what is now referred to as metabolic syndrome associated fatty liver disease, or MAFLD, which is becoming a major factor for development of cirrhosis and end-stage liver failure. Sleep apnea is a very common concomitant comorbidity in people with PCOS. And remember, it's not always just tied to increased BMI. We can see sleep apnea even in women who have just a slight increase in their BMI. So someone who's complaining of excessive tiredness, fatigue, who you think complains of snoring, keep a high index of suspicion, simple enough to do a sleep study, and then further treatment as necessary may be needed for sleep apnea. Depression, altered body image issues, eating problems, all these are very common among young girls, particularly with PCOS, and it's important to keep this in mind. Look for it, think about it, screen, and if necessary, refer to a counselor or a psychiatrist as the case may be. Now, last but not the least is insulin resistance. We talk a lot about insulin resistance in PCOS, and I would say that every young girl who presents with features of PCOS has some element of insulin resistance. It is not necessary for making the diagnosis, but it plays a central role in pathogenesis. Some authors and some experts estimate that it affects all women with PCOS. In general, PCOS women are more insulin resistant and hyperinsulinemic compared with age and BMI matched control. So we are all aware of the lean PCOS phenotype, the obese PCOS phenotype, but just remember that if they are presenting with irregular periods and some hyperandrogenism, more than likely they have some element of insulin resistance. When we were looking at our data, we realized that young girls who gain even as little as 3 to 4 kilos in the abdomen start developing insulin resistance features. So you don't need to have a very high BMI or gain a lot of weight to develop PCOS. Just a little bit of weight gain tips particularly Indian women into a more insulin resistant phenotype and makes the PCOS flare up. But what are the clinical correlates of this insulin resistance? We have to look for metabolic syndrome in all girls and women who present with features of PCOS. So measure their waist circumference, definitely measure their blood pressure. Never forget to check the blood pressure. Get a glycemic profiling done. You can do either a fasting HbA1c or do a 75-gram GTT lipid profile. I find a HSCRP beneficial to point out to these women. All other parameters may be normal, but an elevated HSCRP may be the only clue that there is a underlying insulin resistance and inflammation, and it drives home the necessity for lifestyle modification to a lot of people. And it also helps us determine or re-emphasize the lifestyle modification that is necessary. Remember that insulin resistance is associated not only with PCOS, a lot of these women obviously have acanthosis, but it also increases chances of acne and hirsutism. But it's also associated with a number of other factors like reactive airway disease, COPD. Insulin resistance increases the risk of many malignancies, including breast cancer, colon cancer. In old age, it's associated with increased risk of arthritis, dementia, inflammation, atherosclerosis, apart from all of these factors that we are familiar with, things like fatty liver, dysglycemia, and dyslipidemia and PCOS features. So remember that insulin resistance and inflammation is at the core of a lot of the non-communicable diseases that we are going to be seeing in these women as they live out their life. So what test do we need to make a diagnosis of PCOS? Clinically, like I mentioned, we have to check their BMI and their blood pressure. Definitely check at least a thyroid function and a prolactin at baseline. If you have any doubt about POF or hypothalamic amenorrhea, check an FSH. Do check a testosterone and a DHEAS/17-hydroxyprogesterone. Do a metabolic profiling. Check an ultrasound of the abdomen, preferably a pelvic ultrasound, and then AMH. Now, the current 2023 guidelines, earlier it was mentioned that AMH is not useful for diagnosis of PCOS, but currently they are recommending that AMH may be used as a surrogate for an ultrasound appearance of PCOS. It's not necessary to make a diagnosis. This is from a guideline which came out a year ago, and it should not be used as a single test for the diagnosis for PCOS. It should not yet be used in adolescents because we don't have large enough population data to know what is the normal level in adolescents. Either CM-AMH or an ultrasound may be used to define polycystic ovarian morphology. However, they recommend not doing both the tests. So, for example, for some reason you're not able to get an ultrasound, you can do a AMH. Remember that AMH generally peaks between the ages of 20 to 25 years in the general population. Women who have a higher BMI tend to have a lower AMH, and AMH again may be suppressed by use of oral contraceptive pills, and it can vary across the menstrual cycle. So similar to the way we interpret LH, FSH values, interpret AMH values also, but it is now being recommended as a diagnostic or a diagnostic marker in lieu of an ultrasound abdomen for the polycystic ovarian morphology. We don't necessarily need to do an LH-FSH ratio. Remember that it can be normal in 50%. Obesity, in fact, lowers LH. Some other controversies in PCOS, use of metformin in the absence of IGT is being done more and more commonly. How long we need to continue it, I don't think anybody knows, maybe indefinitely, if it is helping them. Now, coming to the type of contraceptive pill, I'll talk a little bit about the controversies regarding the type of oral contraceptive pill, but they remain the most commonly used medication for management of PCOS. So these are the goals of therapy. We need to make sure that we are protecting the endometrium from unopposed estrogen stimulation. We try to achieve this with regular bleeding. Of course, the skin manifestations, depending on if it's bothersome for the person, we need to be treating the hirsutism and acne. Very important to reduce their risk for other factors related to the insulin resistance, not just the diabetes and dyslipidemia. Remember the fatty liver and all the other factors that I mentioned, which will play a role later on in life. And obviously, discussion of fertility issues always arises. Menstrual cyclicity, we either use a progesterone withdrawal or the contraceptive pill using either a combination of ethinyl estradiol, cyproterone, or ethinyl estradiol with some other progestogen. Insulin sensitizers do play a role. So sometimes they're used in combination, particularly when there is evidence of insulin resistance. Treatment of hirsutism or acne, various combinations of anti-androgens may be used. The contraceptive pill combined with finasteride, combined with spironolactone, flutamide should be avoided because of the hepatotoxicity. In general, we don't use it in our country, but combination of 1 or 2 or 3 of the other anti-androgens is helpful. Again, insulin sensitizers have some role to play in reducing hirsutism and acne. Obviously, improving insulin sensitivity is with the use of metformin. Anti-androgens also have been shown to have a role in improving insulin sensitivity. By reducing androgen levels, insulin sensitivity is re-established. Ovulation induction, again, to this audience, I don't need to go into detail. You're all well versed with it, but insulin sensitizers, again, play an important role. So finally, in the next few slides, I want to talk about the oral contraceptive pill and its use in PCOS. It has been the first-line therapy for management of PCOS. It's helpful in controlling not only the menstrual irregularity, but it reduces acne, hirsutism. It also helps to control dysmenorrhea, menorrhagia. It helps to reduce premenstrual syndrome. It may help to reduce their menstrual migraines. And it's got other benefits also. So they've remained the sort of the first recommendation in PCOS, apart from lifestyle modification and making sure that we are addressing their insulin resistance. The estrogen part of the OCP helps to suppress the FSH. It potentiates the progestin. It suppresses the dominant follicle. One of the most important ways in which it helps in PCOS is that it increases the SHBG, which leads to a reduction in the free androgen levels and thereby reduces the skin manifestations of the excess androgens. The progestin component also helps in reducing the frequency of GnRH pulses and suppresses the LH. It inhibits the LH surge. It improves the endometrial receptivity. It improves the cervical mucus quality. And it also plays a role in reducing the secretion of androgens from the ovaries and also the estrogen. And it also has a somewhat of a lesser effect in increasing SHBG. So the combination of the estrogen and progesterone in the contraceptive pill has several sort of additive benefits in helping in PCOS. The FOXY guideline recommendation, which came out a few years back, said that for the management of hirsutism, particularly in our country, the ethinyl estradiol with cyproterone acetate with temporary hair removal methods is recommended as first-line therapy. And if this is not effective, then we can add other anti-androgens like spironolactone or finasteride. What is important to keep in mind is that anti-androgens or other contraceptives obviously have to be stopped at least 6 months before they plan pregnancy. Quite often in our country, people come and tell us, well, I'm going to be getting married next month or in a couple of months. I generally stop the medications even then, because even if they say, no, I'm not planning a pregnancy after marriage, invariably they'll end up becoming pregnant. So stop it as soon as they tell you they're going to get married. Stop the anti-androgens at any rate. And when it comes to acne and alopecia, again, cyproterone was found to be better suited. It's a grade A evidence. And any combined contraceptive pill which has a combination of the cyproterone acetate, drospirenone or desogestrel has a good effect in reducing hirsutism and acne. In adult women with PCOS who do not intend to conceive, low-dose oral contraceptive pills with cyproterone acetate has been shown to be beneficial compared to other progestins in the Indian context. It's also very helpful for management of acne lesions. In fact, again, in the Indian context, and particularly for us, it's been found to be, and I'm sure we all use this combination, and we find it very beneficial for the skin. And we can use combined oral contraceptives in adolescents. Depending upon the clinical presentation of the acne, this is something where we need a multidisciplinary approach with interaction between the dermatologist, the gynecologist, and an endocrinologist. All types of skin lesions improve with the use of cyproterone acetate, ethinyl estradiol. For example, the appearance of pustules, nodules, comedones, papules, all of this significantly reduced at the end of 6 months in this one particular study. It's also very helpful in reducing hirsutism. So in the frequency of shaving or hot wax treatment can be reduced as early as 3 months. And I know clinically, we know that people come back and tell us, let's say we give these medicines for a year, we stop, it tends to come back after a few months. All that it means is we have to go back to giving it for another few months, side by side, combine it with some other more permanent form of treatment like laser. So the way I always counsel patients is medications may help to reduce it, say by 50 to 60%, the hirsutism will come down by 50 to 60%. But once you stop, over time, it tends to come back. Laser treatment gives a more permanent effect. Using both together for about 6 months to 1 year gives you the best, most likely to be permanent form of treatment. So use your anti-androgens, use the combined oral contraceptives combined with laser treatment for a good chunk of time, and you're going to get the best results as far as the skin is concerned. But there has been a reduction in Ferriman-Galway score ranging from a reduction by 25 to 50% at the end of 6 months with the use of the ethinyl estradiol cyproterone combination. Now, this is a very distressing problem for which there is no good treatment, which is frontal balding or alopecia. There is really no good treatment for it. Dermatologists do their sort of, they have their PRP and they do other sort of treatments. It works partially, I would say. There is some limited data to say that the use of cyproterone acetate ethinyl estradiol has shown good results in small studies, even in the androgenic alopecia population. And it's worthwhile trying this for a while to see if they improve with this treatment. In general, when we look at the usage of oral contraceptives in PCOS, I'll share some data to show that there is a significant reduction in hyperandrogenic biomarkers, particularly in people with proven biochemical hyperandrogenism and menstrual disturbances. Combined oral contraceptives would have greater benefits when the androgen levels are high. In earlier days, when we had the COCs with higher doses of estrogen, this I'm talking about 50 micrograms of ethinyl estradiol and higher, those were the pills which tended to cause a change in their metabolic syndrome, increases the blood sugar, increases the cholesterol, increases the blood pressure. With the currently available combined oral contraceptives, we generally do not see a problem of worsening of metabolic parameters, but there are individual differences. Certain people may react in a different way, so it is important to keep it in mind. Always check their sugar and lipid profile before you initiate any combined oral contraceptive pill. And if you're going to keep them on it long term, definitely repeat it at least at the end of 6 months to 1 year. Meta-analysis which came out in 2022 showed that particularly with the usage of the ethinyl estradiol and cyproterone acetate pill, there was also a significant increase in the sex hormone binding globulin. With this type of the OCP, there was an increase in the SHBG. And because the SHBG goes up, there's a significant reduction in the free androgen levels, which then leads to a significant improvement in clinical hyperandrogenic features. And also, if you look at the effect of the comparing the various combined oral contraceptives on the reduction in the LH-FSH on the hypothalamic pituitary gonadal axis, you can see that the most reduction in LH-FSH, the LH to the estradiol levels, the testosterone levels, the most reduction occurs with ethinyl estradiol with cyproterone compared to other combinations of contraceptive pills. So COCs containing cyproterone showed the maximal decrease in LH-FSH levels even after 3 months, but up to 1 year. And the maximum effect on gonadotropin suppression was seen. So products that contain cyproterone have the greatest suppressive effect on gonadotropins and estradiol. And this may be a good option for treating PCOS, particularly those who have hyperandrogenemia and a lot of skin manifestations. How does it compare with, say, something which contains drospirenone and ethinyl estradiol? You can see that the extent of reduction in the Ferriman-Galway score is much better with the cyproterone combination as compared to the drospirenone. The free androgen index drops a lot more with cyproterone compared to drospirenone. So the combination of cyproterone with 35 micrograms of ethinyl estradiol has been shown to increase the SHBG level significantly as compared to the drospirenone also, while helping to reduce other markers of hirsutism significantly. The other important clinical factor that makes a difference is the incidence of breakthrough bleeding with this particular combination. Ethinyl estradiol 35 micrograms with cyproterone 2 milligrams is very low. In this particular study, it was shown that the incidence of breakthrough bleeding was only 4% with this particular combination as compared to somewhere between 12 to 25% with drospirenone, whether it was combined with ethinyl estradiol 35 micrograms or 20 micrograms. So the fact that the incidence of breakthrough bleeding is very low means that compliance is improved. And people obviously would prefer to use something like this. There is no evidence to show that lowering the estrogen content below 35 micrograms lowers the risk of VTE. We should not be, and this is no longer available, we are not using the COCs which contain the much higher dose of ethinyl estradiol, but lower levels of ethinyl estradiol may not increase the risk of VTE, but anyhow, we need to be careful. in all young women in whom we are going to consider using combined oral contraceptives for a prolonged period of time. Always assess. There is a checklist which is available from the Endocrine Society about people who are going to have adverse effects from the prolonged use of combined oral contraceptives. So let's say we have someone who is obese in the early to mid 30s, who is a smoker, who's got dyslipidemia, who's got hypertension. This is the type of person I would be wary about using combined oral contraceptives for a prolonged period of time. Whereas if you're taking a younger woman for whom we are just going to use this for a limited period of time for acne and hirsutism, who is thin, who's got normal metabolic profiling, I would not be worried about or concerned about the effects. Another important area where anti-androgen treatment with the cyproterone ethinyl estradiol combination is helpful is in improving pregnancy rates. So in this particular study, they took close to 600 women with PCOS. And in one arm, they were given ethinyl estradiol cyproterone followed by ovulation induction. In the other arm, they just went straight to ovulation induction. And this was over a period of 3 to 6 months. In the group that received cyproterone ethinyl estradiol followed by ovulation induction, the pregnancy rate was 50%, whereas it was only, 14% in the group that did not receive the anti-androgens. So in general, PCOS women who do not respond to ovulation induction for pregnancy are better treated by first pre-treating them for 3 months with cyproterone ethinyl estradiol, followed by ovulation induction. The incidence of pregnancy-related complications is also less in the group that were pre-treated with CPA-EE. In this case, you can see that the incidence or the prevalence of gestational diabetes was significantly lower. Pregnancy-induced hypertension was significantly lower. Premature delivery also came down in the group. So the red bars are the women who were pre-treated with cyproterone ethinyl estradiol before ovulation induction and pregnancy. So it's helpful in improving the chances of pregnancy and improving the reducing the complications during pregnancy. Other anti-androgens, which I'm not going to be talking about, which I had mentioned earlier, apart from combined oral contraceptives, are finasteride, spironolactone, and very rarely do we use dexamethasone, particularly when there is persistent elevation of DHEAS or there is some suggestion of non-classical CAH with a elevated 17-hydroxyprogesterone levels. Again, using it for a short period of time not only helps to improve hirsutism, acne, alopecia, it obviously also helps in ovulation induction and pregnancy. So I'm going to finish up by saying that PCOS is a whole constellation of signs and symptoms that go across the lifespan. I mentioned in that first slide that it can present with early adrenarche. It actually even presents even earlier within the womb itself. You need age-based assessment. In the adolescent, the assessment is different from the 25-year-old lady, from the 50-year-old lady. So you need age-based assessment and the treatment tailored to the most relevant complaint at that point in time. And metabolic reproductive syndrome due to insulin resistance is also a good way to think about it because it focuses the attention on the metabolic aspect of PCOS. I shall stop here and happy to answer any questions if any have come up. Thank you very much.
Thank you very much, ma'am. That was a very insightful session, wonderful session, especially getting it, from an endocrinologist perspective. We've have a lot of questions, but because of time constraint, we'll pick a few.
Sure.
Okay, Dr. Hemant Bhatt from Mumbai asks regarding some insights on the treatment of infertility in patients with PCOS.
So I can tell you an endocrinologist perspective because I leave that to my gynec colleagues. I don't get involved at all. But some of the things that as endocrinologists we do is make sure that all of the other hormones are okay. If they've not had, I mentioned the 3 androgens, but also periodically check their thyroid and prolactin. Hyperprolactinemia is a very common, I didn't spend much time today talking about it, but in India particularly, I would say close to 30 to 50% of young girls with PCOS have marginal elevated prolactin. Adding some cabergoline, reducing the prolactin not only helps obviously with their fertility, but it also helps with the skin manifestations. So one aspect is I make sure that all their hormones are as close to normal as possible. Attack the insulin resistance as much as you can. The more weight they lose, the better off they are. And looking for aspects of insulin resistance is important. It's not enough to just look at their fasting sugar or, fasting blood sugar, insulin, HbA1c. I look at the uric acid, lipids. I talked about hsCRP. So attacking the insulin resistance, making sure that they sleep properly, exercise regularly. I think all these are very important aspects as far as I'm concerned to help improve their fertility.
Okay, thank you, ma'am. I hope sir gets the answer with this, gets the answer with your response. Dr. Sangeeta from Tamil Nadu, Coimbatore, asked regarding ovulation induction after a 6-month gap after combined OC pills.
So I think if the androgens are under control, if there is no clinical or biochemical feature of hyperandrogenism and the periods have been regular, I think I would say it's okay to go ahead. So generally, when we've used combined oral contraceptives and the hormone levels have come down significantly, usually studies have shown that they remain down for anywhere from 6 months to 1 year. And then they may start going up again. So basically, the genes are completely down-regulated, and then it may start going up again. If the hormone levels are okay and the periods have been regular in between, just go ahead and get started on your OI would be my suggestion. If the hormone levels are high, then do another 3 months and then follow it up with the OI.
Okay, thank you, ma'am. Dr. Ratika from Tamil Nadu asked regarding the role of myoinositol in PCOS.
So the way I think about myoinositol is I think it's okay to use it. I think the data regarding it is very soft evidence, but it doesn't harm. And certainly there are some girls who believe that it really helps them a lot. When you talk to patients, per se, from a patient perspective, they feel that it helps them and it's not going to harm them. So certainly use it.
Okay, thank you, ma'am. We have another question. In case of a gender change surgery that happens, like male to female, is there any role or usage of an anti-androgenic OC pill? Like how long can it be given?
So that is a completely different topic. In general, I mean, we do use a combination of estrogen and progesterone. If they have had gonadectomy done, then we can get away with using something like the pill. If they've not had a gonadectomy done and they have their native male hormones still present, we need very, very high doses of estrogen and of course the progesterone. So that is a very separate management issue,
Okay.
and that has to continue indefinitely. Once you stop, in general, it tends to, the male features tend to come back. The skin features particularly tend to come back. So at least for 20 years, 25 years, if you're going to start at the age of 20, 25, it has to continue.
Okay, thank you, ma'am. Dr. Nidhi from Mumbai asks regarding cardiac changes with cabergoline. So how safe is it to give? Since I think they had an episode where 2 young girls suddenly had cardiac-related issue.
So, see, this thing about cabergoline and cardiac-related issue is mainly in the doses that are used for Parkinson's disease. So there, cabergoline is used at a dosage of 6 to 8 milligrams per day. And in that population, at the end of 1 year of use or something, or even more years, I think 3 to 5 years of use at that very high dose, there was a thickening of the tricuspid valve that was seen. So that is mainly our concern as endocrinologists. If I'm going to keep a woman on cabergoline for, say, a microprolactinoma due to whatever reason, or a macro, we are more likely to use it long-term in a macro, try to get them to the minimum dose that will keep the prolactin under control. So as long as you're achieving a prolactin of about 10, it's okay. If they're going to remain on a cabergoline for more than 5 years, I get an echo done just for, partly, I would say, medical legal reasons and to reassure. We do have this conversation. But I'm not particularly worried about it because I know that the dosage that I'm using is not high enough to cause problems. This we are talking about, a cumulative dose of something like the dose that we generally use is roughly about 1/10 to 1/50th of the dose that I would be worrying about cardiac issues.
Okay, thank you, ma'am. We have another question regarding cyproterone. So from Dr. Sangeeta again, regarding do we have to wait for a washout period when the patient is on cyproterone and then desires pregnancy?
Not necessary. I think because it's a fairly short-lived medicine, I mean, the effect on the LH-FSH lasts for a longer period of time. But once you stop, they can try on their own. You don't need a washout period. The washout period is only for other anti-androgens like spironolactone.
Okay.
where you have to wait for at least about 2 months.
All right. Thank you, ma'am. Do you want to take some more questions, ma'am, or
I don't mind.
Okay.
We have another 10
So
minutes. Yeah.
yes. So Dr. Nidhi from Mumbai again asked another question. It was when they had seen the cardiac issue, they had given the dose of 0.5 twice weekly for about 6 weeks.
What sort of cardiac issue, if I can ask?
This is in reference to cabergoline.
I know. But what was the cardiac issue?
We do not have the details. Maybe, we can ask Dr. Nidhi to maybe email you the query.
Yeah, I think
Later
that would
on,
be
then
good.
a
That would
detailed
be good.
discussion can
Yeah,
happen.
yeah.
Yes. Yeah. Okay. So Dr. Varsha from Lucknow asked regarding metformin. So how long do we prescribe metformin in PCOS?
There is no sort of upper limit or no recommendation about how long we need to use it. If they have achieved, and you need to use a good dose. For most people, they only respond at about 1.5 grams per day. So somewhere between 850 twice a day. If they are a lower BMI, maybe 500 twice a day. If they're responding well, reduce it to once a day and see how they do. If they're doing well with once a day, regular periods, all of that, stop and see. If they do well with it and they don't do well without it, indefinite use is okay. You're on mute.
Yeah. Dr. Sushma from UP asks, at what age can, or how young, at what young age can a girl be prescribed an OCP?
OCP, even as young as 12 and 13 years, sometimes we do use it for various indications. Yeah. So, but that personally only use it for a very, very short period of time in that situation, maybe for 2 or 3 months, not for a prolonged period of time.
Okay. Another question is there any drug or any protocol that can be prescribed for weight loss in PCOS?
So I firmly believe in following a low carbohydrate diet. Ultimately, weight loss only occurs when you eat less calories and you eat less carbohydrate. So having more protein and fiber and less carbs and exercising with metformin, with sometimes the usage of other weight loss medications, particularly the GLP-1 receptor analogs, is particularly helpful. I think more and more what I think doctors are beginning to find is once they put people on the GLP-1 receptor analogs, the semaglutide, that class of medications, people are actually becoming pregnant. They're losing weight and they're becoming pregnant.
Okay.
No problem. You don't need to worry about it. Just make sure the sugars are okay when they conceive, the usual precautions that we say. But it just drives home the point that the weight reduction is what is important to taking care of the PCOS.
Okay. Another question is regarding role of GnRH analogs. So other, especially in your endocrinology practice, where does this molecules fit in GnRH analogs?
We only use it for precocious puberty or for, ovarian hypertrichosis or something like that. I don't use it for any other indication in general.
Okay. Dr. Sayani Das from Kolkata asks, like, what would be the management of a patient with known PCOS who experiences periods only after OCPs, otherwise having periods 7 times a year without OCPs? So this is a 19-year-old girl having a BMI around 30.
So as long as they're getting about 6 periods a year, I think that's acceptable. I would not try and push it to, trying to get it more regularly.
Okay.
So some people continue to have just periods once in 2 months. That's absolutely fine. If they're getting it on their own without tablets, that's perfectly acceptable.
Okay. Thank you, ma'am. So Dr. Mohammad Iqbal from Srinagar, Jammu Kashmir, asks regarding if there's an alternative to metformin as an insulin sensitizing agent, any other drug, anything alternative.
Yeah, alternative is obviously pioglitazone. And there are some doctors who use it. It's actually a far more powerful and effective insulin sensitizer. Some doctors use it if either the person cannot tolerate metformin, you can consider using pioglitazone. And it's also helpful, for example, in some cases where the ovulation induction has not worked. In that situation, I know some fertility centers use pioglitazone. No major concerns with the dosage of 7.5 to 15 mg, very well tolerated, no gastric issues. However, the only thing we need to be cognizant of is it causes some weight gain and it causes some water retention. So we have to just be careful. Just keep that in mind, but very, very powerful insulin sensitizer.
Thank you, ma'am. Thank you very much for the wonderful session. I would request the audience, if you have any more of the questions, you can write to ma'am via mail. Is that okay, ma'am?
Yeah, that's absolutely fine.
So then a detailed discussion regarding the case, because we have so many questions, it will be very difficult to pick all of them and have a detailed discussion on this platform right now.
Yeah. Can I just share my email? Sorry, because
Yes,
I didn't do that, I think.
Yeah.
Shall I put it in the chat box or?
Yeah, you can put it in the chat box, ma'am.
Okay. Thank you very much. I mean, I had a really good time. Yeah, I'm just putting it.
Yeah. Thank you very much, ma'am. So the entire session was very insightful, especially when we get a different perspective, clinicians from an endocrinologist perspective. So we understand what happens on the other side also. We had an overwhelming response when it came to, even the questions are still flowing in. And all the audience were very enthusiastic listening to your session. Thank you very much. And a big thank you to the entire team and the entire audience for this wonderful session. Thank you.
Thank you. Thank you so much for arranging this. Thank you.
Thank you, doctor. This is Balaji. Thank you.
Yeah, thanks, Balaji. Bye-bye.
Thank you, ma'am.